Kristen here at UT Southwestern Medical Center. Thank you for joining our chat today on brain tumors with Dr. Toral Patel. Dr. Patel is a neurosurgeon with the Peter O'Donnell Jr. Brain Institute here at UT Southwestern. We're excited to have her as part of Brain Tumor Awareness Month. It's a very important topic. You know, as always, don't forget that this chat should not replace a doctor's appointment. You definitely want to get in to see a clinician if you need to, but we're going to take as many questions as we can get in the next 20 to 25 minutes. So leave them in the comments field and we'll take them as we go along. So we're going to go ahead and get started though. Dr. Patel, thank you for joining us.
Thanks so much, Kristen. Thanks for having me. I'm looking forward to it.
This should be a really interesting conversation.
Yeah.
Brain tumors seem to have been in the news a lot more lately, and we can get into that later. But just to start, what are the most common types of brain tumors?
Yeah, so I think it's a great starting point when we're thinking about brain tumors. The sort of biggest designation to make initially is tumors that start in the brain. Those are called primary brain tumors, or tumors that metastasize to the brain from other parts of the body, i.e. lung cancers or breast cancers. Those are called secondary brain tumors. It turns out that secondary brain tumors are far more common just because breast cancer, lung cancer, things like that are more common in our general population. But as a neurosurgeon, I tend to see primarily primary brain tumors, and that's what most people think about when they think about brain tumors. And primary brain tumors can then be subdivided into two main classes: benign tumors, which represent the majority, things like meningiomas and pituitary tumors, and malignant tumors, things like gliomas that are forms of brain cancer.
Okay, great. So I see the questions are already coming in. This is great. And I know we were going to talk a little bit about symptoms, and this actually addresses that perfectly. It's a question from Tony, and her question is, are vision irregularities a potential warning sign for brain tumors?
Yeah, Tony, that's a great question. And the short answer to that is yes. The longer answer is vision problems are relatively nonspecific, and many of us will have changes in our vision. It's just a normal process of aging. But brain tumors specifically can cause vision problems. And so pituitary tumor is a type of benign tumor that I mentioned earlier, is a tumor that happens at the base of the skull just behind the eyes. And if a pituitary tumor grows big enough, then it can, in theory, compress the optic chiasm, which is part of the visual pathway where the two optic nerves from the eyes mix. And so if you have a big enough pituitary tumor, you could have black spots in your vision from pressure on that optic chiasm. And similarly, if you have a big enough brain tumor in other parts of your brain, and that's increasing the pressure in your brain, you can get indirect changes in your vision, a blurring of your vision most commonly. And so any new vision changes like that would mandate a workup with your physician, your primary care doctor, your ophthalmologist, and some quick tests can help to determine whether or not the cause is from your eyes itself, just normal eye-related things, or if it's from the brain. And that's pretty easy to distinguish on a physical exam.
Okay. Great question, Tony. Thanks for joining and thanks for the question. Related to that, what are other signs and symptoms that individuals should look out for?
Yes. The most common presenting sign of a brain tumor is headache. And I say that with caution because headaches are common also. And so I don't mean for people to think that every time they have a headache that they should run out and get an MRI or see their physician because they have a brain tumor. But warning headaches and brain tumor related headaches have very particular characteristics. So new escalating headaches that are unusual for you, headaches that tend to occur late at night or first thing in the morning, headaches that wake you up from sleep, all of those are very unusual headaches and mandate a workup with your primary care physician and could be a warning sign of a brain tumor. Additionally, seizures are a very common cause of very common symptom of brain tumors, and so seizures are basically electrical haywire in your brain, and if you have a tumor that's compressing part of your brain, then the electrical circuitry in that area can go awry, and then a patient, you can have a seizure. And so if you ever have a seizure, that mandates workup, and it could be a sign of a brain tumor. Could also be a sign of other conditions, and so the workup would need to be thorough, but that's one thing to look for. And then if the brain tumor is in a particular part of the brain, the motor area or the speech area, then you might have impact on very specific neurologic functions like the ability to get your words out, the ability to remember things in your short-term memory, the ability to move one part of your body, the right side or the left side, for example.
All right, great question. So, moving on, we've got a different question here from Christy, and her question is about treatments. What treatments are available?
Yeah, so anytime you have a new diagnosis of a brain tumor, there's a pretty standard treatment algorithm that every physician should think about. First is surgery. Is surgery appropriate for this type of tumor? If so, is the goal of surgery to get a biopsy and get a diagnosis, or is the goal of surgery to remove the whole thing in a curative manner? The second thing to consider is radiation. If the tumor is malignant, or if the tumor is in a particular part of the brain where surgery is not safe, is there a role for radiation as part of the treatment? And then the third thing to consider is chemotherapy. And so many chemotherapies will not penetrate the brain very well, and so that often sort of takes a back burner to surgery and radiation. But many chemotherapies do have some efficacy in the brain, and sometimes we use them. And so for every brain tumor, we go through that treatment algorithm. More benign brain tumors tend to be treated with surgery or radiation, often in a curative manner. And brain cancers like glioma often require a combination of all three.
Okay, great question. I see another one here from LaDonna. I do want to make sure before we get too far along, though, that we thank the Head for the Cure. Their team has been great at helping share the information about this chat and promote it. And obviously the team over at the O'Donnell Brain Institute has been instrumental as well. The Cure's a question from LaDonna. And have there been any new technologies in the last couple of years for inoperable brain tumors? And are they being used at UT Southwestern?
Yeah, so the answer to both of those questions is yes. Inoperable brain tumors we typically think of as deep-seated tumors that are perhaps in very eloquent or highly important parts of the brain where you wouldn't necessarily want to remove the brain for fear of the side effects. And there's newer strategies that have been developed to address these kinds of tumors. One is gamma knife, which is a focused type of radiation. Knife is a bit of a misnomer. There's no knife involved, but it implies precision, and that type of radiation is very focused and can access inoperable portions of the brain, delivering high doses of radiation to the tumor alone and sparing the normal brain around it. And we have the only gamma knife unit in all of North Texas on the UT Southwestern campus, and the most advanced one, and we routinely treat patients with deep-seated brain tumors on that machine here. In addition to gamma knife, there's something called laser interstitial thermal therapy. If you've seen it on the internet, it's sometimes abbreviated as LITT, L-I-T-T. And in that treatment, a small laser is passed into the brain through a minimally invasive technique, a very small hole in the brain. And that can access very deep-seated tumors because the pathway through the brain is minimal. And then using an MRI in real time, you heat up the laser, the patient is asleep, and you can see on the MRI when the tumor gets to a high enough temperature that it's been ablated or killed. And then the laser is removed and the patient is woken from anesthesia and typically goes home the next day.
Wow, that sounds amazing.
Yes,
It's
real progress.
Yeah, thanks for the question, LaDonna, and for joining us. So, when we're talking about treatments and technologies, it seems like women are more susceptible to some of these conditions, particularly meningiomas. Do we have any idea why that is?
So that's a very important point, especially considering our audience. So in general, men are more commonly affected with the malignant brain tumors like the gliomas, but women are much more commonly affected with benign tumors, as Kristen said, like meningiomas. In fact, women are 2 to 3 times more likely to have a meningioma than men. And meningiomas as a whole make up 1/3 of all of the brain tumors, the primary brain tumors. And so you can imagine if meningiomas make up 1/3 of the whole group and women have 2 to 3 times more likelihood to have that tumor, then there's a ton of women with meningiomas. And we don't know exactly why women get them more often than men, but there is a theory that it's hormonally based. And part of that understanding is that when you remove a meningioma and do some high-level pathology on it, you can see that the meningioma cells express receptors for estrogen and progesterone. And of course, women have higher levels of those circulating hormones than men do, and so there's a theory that the reason that women have more of these tumors is this hormonal basis.
Gotcha. Okay, great question. So here's another one, a follow-up from Christy, and it goes to prevention.
Yeah.
Is there anything people can do to prevent brain tumors?
Yeah, the short answer to that is no, or at least we don't know yet. There's nothing that's been conclusively proven in terms of diet or exercise to increase or decrease your risk to forming a brain tumor later in life. And so I think the general medical advice is live a healthy life, meaning get plenty of exercise, eat a well-balanced diet, and I suspect that 30, 40, 50 years from now, we'll have enough data that we will be able to prove some relationship between these lifestyle choices that you make now and your outcomes when you're older. We just don't have the data to say that currently. The only known environmental sort of culprit that's been conclusively linked to a higher risk of brain tumors later is radiation. And so if you live in an area certainly where there's radiation around, then that's something to be aware of. In general, in the US, we have very high levels of radiation safety, and so the general population is not exposed to untoward levels in the ambient environment.
Okay, good question. So talking about, requiring surgery and radiation, various treatments, does removing a brain tumor always require a craniotomy? It seems like that's kind of the most invasive.
Yes, that's a great question. So a craniotomy, as Kristen said, is an opening in the skull that allows a neurosurgeon like myself to access the brain and then the brain tumor and remove it. The skull is replaced at the end of surgery and you're sewn up and the patient looks whole, but it is an invasive procedure. And many brain tumors will require a craniotomy to remove, maybe 80%, 85%. But there is a class of brain tumors that can be removed in a less invasive way or a minimally invasive way. And the most common of those are pituitary tumors. That's that tumor that I mentioned that sits at the base of the skull just behind the eyes. And the way that we remove those tumors, which encompass 10 to 15% of primary brain tumors, is actually through the nose with a series of small cameras called endoscopes. And there's no incision on the face at all. It's a much less invasive manner of doing this than was done 20 and 30 years ago. And so the recovery is much quicker, and using a set of cameras, small instruments, and going through the nose, a tumor in the pituitary area can be removed completely more often than not.
That's amazing. It's really amazing.
It is great for patients.
Wow. So we have a couple more questions here. I do want to remind people we have maybe 8 to 10 minutes left. So if you've been holding on to your question, now's a great time to submit it. We have one here from Karen. And Karen's question, is there anything that can remove radiation necrosis? My husband is an 18-year survivor, and radiation necrosis is said to be causing some gait and balance issues.
Yeah. Well, first of all, Karen, congratulations. The answer in terms of treatment for radiation necrosis is yes, there are ways to treat it. And there's surgical methods and there's non-surgical methods. And so a surgical method, depending on where the radiation necrosis is located and if it's focal, would be a craniotomy to remove the offending part of the brain. Typically that's not functional brain, and once you remove the sort of nidus of the radiation necrosis, the swelling will settle down. If it's in a deep-seated portion of the brain, then you can use that same technology that I mentioned earlier, laser interstitial thermal therapy, or LIT, to go in and actually ablate the focus of radiation necrosis, and paradoxically killing this already dead thing really is quite effective, and then the swelling and side effects that are a result of the radiation necrosis will go away. If those things aren't options because the radiation injury is more diffuse, then there's things like hyperbaric oxygen therapy or Avastin in infusion, or some people have even tried aspirin and vitamin E with some limited efficacy. So that's sort of the menu of options for treating that. And again, congratulations to your husband.
18 years is wonderful.
Yes.
So what advice do you give to loved ones and caregivers of individuals who are undergoing treatment for brain tumor?
Yeah, I think it varies a lot between the malignant brain tumors and the benign ones. But I think one thing that's common to both groups is that there's often a lot of fatigue involved in brain tumor treatments. Whether you're going through chemotherapy or radiation or just having surgery alone, the effects of those treatments for at least the 4 to 6 week period immediately after the beginning of treatment is pretty profound, and people are tired. And so as much as you can do to support your loved ones and support their fatigue, whether it's cooking good meals or helping to motivate them to take walks, I think that's really important for their overall health. And then, of course, those things get magnified for our patients and our loved ones who are going through malignant brain tumor therapy, which is much more intensive. But plan for that first 4 to 6 weeks to be a period where you really shower them with a lot of patience and also a lot of love, because they're going to be tired.
Yeah, they're going to be tired. That's what I've heard from lots of people.
And it gets better. So there's hope. You know, it gets better for almost every single patient. But just bear with them for the beginning.
Great. So here's a different question from Daniel, and you guys took it seriously when I said last minute questions. So here's one from Daniel, and it's, as a cutting edge brain surgeon, what are the new ways of non-invasive or minimally invasive treatments? What is the future use of gamma knife in neurosurgery? Yeah. So 2 parts there.
Yes. So those are great questions. As surgeons, we want to really optimize new technologies to make surgery safer and to decrease the amount of time required to recover from any given surgery. And so oftentimes technology can help us to achieve that. We've mentioned LIT already several times, and I think that is an extremely promising new therapeutic. In terms of removing brain tissue from very eloquent parts of the brain, i.e. near motor or speech areas, we can map out the electrical circuitry of your brain while you're under anesthesia, and previously all of that had to be done while a patient was awake, which was a much more sort of involved ordeal for most people, and so that application of technology makes surgery much easier for the patient to endure. For malignant brain tumors, particularly something called the glioblastoma, there's something called the Optune device, in which sticky pads are placed all over a patient's scalp. And through these sticky pads, electrical currents are transmitted through the brain, and they interfere with the tumor's ability to grow. And it's a completely new and different way to treat a brain tumor besides chemotherapy and radiation and surgery. And the data so far is quite promising that this treatment modality called tumor treating fields has promise. And anecdotally, my longest term survivors from glioblastoma have all used this device, and so I think that this holds a lot of promise and likely will be optimized in our lifetime to be easier for the patient to use. Gamma knife continues to really explode in its indications, and we have one of the busiest programs in the country now here. And it's very effective at treating brain metastases, so each individual tumor has an over 90% success rate with gamma knife treatment. And we can use it to treat more and more benign tumors if we catch them at a small size before they're causing symptoms, and hopefully avoid surgery altogether.
Wow, great questions. Sounds like there's a lot of progress moving forward.
There is. I think the way that we practice neurosurgical oncology now is completely different than even 20 years ago.
Well, we've got a question here from Kim, and the question is, can you give a second surgery due to an original brain tumor surgery?
Yeah, so I think the question, hi Kim, is probably, if you've had one brain tumor surgery, is that it? Or can you have another one in the future if there's a recurrence? And the short answer to that is yes, you can. Well, if there is a tumor that's previously had surgery or even chemotherapy or radiation or all of the above, and then the tumor recurs later on down the line, then the surgeon is responsible for thinking about that tumor from start to finish just as you would the first time you saw that patient. So is the tumor in a surgically accessible area? Is the patient doing well enough to recover from surgery? And can I take the tumor out without hurting the patient? And if the answers to those questions are yes, and it would provide meaningful benefit, absolutely you can.
Okay, great question. Thanks for joining us, Kim. So we've got a question that came in from Candy. And Candy, she says, I'm a 10-year survivor, so congratulations.
Congratulations, Candy.
Yeah, she says, I had a meningioma removed, and I apologize if I mispronounced that, removed 7 years ago with no regrowth. Do you feel like it can be released from care? Yearly MRIs are very expensive. So kind of what is the average duration of aftercare?
Yeah, so that the answer to that is that varies a lot depending on what grade meningioma you had. And so grade 1 meningiomas are the most benign kind, and they represent 85 to 90% of all meningiomas. And when completely removed, the risk of recurrence is in the single-digit percentages, less than 10% over the first 10 years and likely over your lifetime. But surgeons and physicians in general tend to be cautious people, so even when we're faced with those good odds, we tend to like to follow patients forever, just in case. And that generates a lot of cost and anxiety, and in fact, we're doing research at UT Southwestern to try to understand at what time point can we let you be free of all these follow-up scans, and I hope that we'll have a scientific answer to that question in the next 1 to 2 years. But the flip side of that is my current practice is that for patients who have tumors that are grade 1 meningiomas that are completely removed, I get MRIs once a year for 5 years, and then every 2 years for a period of time, and then every 5 years. And then by then we've all grown old and hopefully we've forgotten about it. But it's rare to find someone that'll just completely set you free because we tend to be cautious people. But again, I hope to have data that tells us the right answer in the near future.
Great question, certainly. So we've talked a lot about different types of brain tumors. Are all brain tumors cancerous? It sounds like no.
No. And so we're talking just about primary brain tumors now. So these are the brain tumors that started in the brain, and many of them will be completely benign. Tumors like meningiomas and pituitary adenomas and other tumors called vestibular schwannomas. Those are sort of the 3 most common ones. And they're benign, not cancerous at all. They won't spread to other parts of the body. And in general, effective treatments for them are surgery and radiation based, and you can live a long, normal, healthy life. There's a class of brain tumors that are cancerous called gliomas, of which glioblastoma is one type, astrocytoma and oligodendroglioma are other common types. And they're cancerous and pesky because they tend to recur despite aggressive treatments, but they still do respond to treatments, and people clearly live longer if you treat them as opposed to doing nothing.
Okay, so we have a rather long question from Peggy that I'm going to go through, but thank you for joining us, Peggy.
Hi, Peggy.
So she gives us a little bit of information. She's 65 years old, female, lung transplant recipient.
Congratulations.
She says, in the past 5 years on her MRI results, it said re-demonstration of small axial enhancing mass along the right parietal convexity, not significantly changed in size compared to the most recent prior performed, but once again, they're, measuring up to 11 millimeters, but once again, minimally larger compared to prior performed in 2013. Do I need to be concerned about this, or is there anything I should be doing? She says, sorry for such a lengthy question.
No problem at all. I'm happy to answer that, Peggy. So it sounds as if they're talking about an extra-axial parietal convexity mass, and not having seen your pictures, if I had to guess about what that was, I'd say it's probably a meningioma, again, the most common of the benign tumors. And meningiomas grow on average 1 to 2 millimeters per year. And so to see a small amount of growth over time, if your tumor is in fact a meningioma, would be very common and expected. Now, meningiomas don't grow every year, and they can grow in fits and spurts. And so they can go through 10, 15 years where they don't grow at all, and then they can go through a year or 2 where they grow more. And so we all believe that it's important to keep an eye on even benign tumors like meningiomas and pituitary adenomas in the absence of symptoms, just in case they grow to a size where we think that treatment is necessary, i.e. surgery. We want to be able to treat it before it gets to a problematic stage where you're suffering a lot of neurologic symptoms. And so if I'm reading your question right and inferring what the scan shows, if it does in fact show a 1 centimeter asymptomatic meningioma, it would be very reasonable to follow that with yearly MRIs to ensure that if it grew at an unusual rate, it was treated sooner than later before it caused you problems.
All right, thank you for joining, Peggy, and thanks for the excellent question. I know we're about out of time, so I want to give Dr. Patel a chance to tell us anything about what should people remember about this chat and about brain tumors.
Well, I think in terms of symptoms, important to know that headaches that are unusual for you, of a different pattern or quality than is typical for you, certainly seizures or any focal neurologic deficits, always mandates a workup with a physician, either your primary care physician, an ER if you can't get in to see your PCP, someone. That shouldn't be ignored. And second, Although in general, sort of the thought about brain tumors is one of a lot of gloom and doom, I want people to sort of be reassured that many brain tumors are completely benign. Our treatments now, compared to 20 years ago, are far more advanced, and you can have very effective treatments that let you live long, normal, healthy lives as long as you do something about it. And so just because you get a diagnosis like this, don't feel like the world is crashing down. In all likelihood, you may have a very treatable condition, and we would obviously be happy to help you here.
Okay. And last question, this one came in from Daniel. If patients need second opinions on their diagnosis, is that option available?
Yes, always, always. So I'm a big proponent of second opinions. I think that the more information you have about your own healthcare, the better you're going to do, the better decision you can make, certainly, and knowledge is power. And so we have a very active brain tumor program here. We'd always be happy to see you in person for a second opinion. If you live far away and you'd like a remote second opinion via our online portal, we also have a mechanism to do that through the UT Southwestern Neurosurgery Peter O'Donnell webpage, which you can Google and find pretty easily, our second opinion program. But absolutely.
Okay, we'll be sure to share a link to that second opinion program for the O'Donnell Brain Institute in the comments feed, so if you're interested, it'll be there. If you know others and want to refer them to, please go. In the meantime, we are all out of time. This has been an excellent chat. All the questions have been phenomenal. Thank you to everybody who participated and submitted a question. Thank you, Dr. Patel, for your time.
My pleasure. Thanks, everyone, for joining us. This is great. Have a good afternoon.
And absolutely, as usual, this will be on YouTube later this afternoon, and it'll also be here on Facebook. So if you have any other questions, feel free to leave them, and we'll get back to you as soon as we can. In the meantime, have a wonderful day. Thanks for joining us.
Bye.